Morning, everyone. My name is Katie Kastner. I'm a developmental behavioral pediatrician here at the Wasteman Center. So I'm delighted and honored to be here today to talk with you guys from a clinician's perspective about this overlap between ADHD and autism. So we just heard a whole lot about where the field is going and what some of our hopes are for the future. And I'm going to talk a little bit more about where we're at right now from a clinical perspective, what we're able to do right now in terms of supporting autistic children who have ADHD. And I will primarily focus on children as I am a pediatrician, but certainly ADHD impacts autistic adults as well. And some of what I talk about is applicable in the adult community also. All right, so here's the things we're gonna cover during our brief time together today. We'll talk about how we define ADHD clinically and also this designation of what's called complex ADHD. We'll talk about the current criteria that we use for a diagnosis and what that evaluation process looks like. And then we'll talk about treatment options. Okay, so we, from a clinical perspective right now, use the DSM-5, which we've heard a lot today about the limitations there. And certainly as clinicians, we all have lots of high hopes for moving towards a more nuanced approach like what James was just describing. But from a clinical perspective right now, the DSM-5 is kind of the standard classification structure that we use to make a diagnosis of ADHD. And we define 3 different types of ADHD from a clinical perspective. So there's an inattentive type, a hyperactive impulsive type, and then a combined type, which has features of both. Now, some folks will ask about ADD and where that fits into this structure. ADD was an older diagnostic term. So attention deficit disorder was a term in a previous version of the DSM. We don't use that anymore. That would fit under this umbrella of ADHD now. So this is a clinical diagnosis. We don't currently have blood tests or brain scans that help us figure that out. So we are relying on the presence of characteristics or symptoms that a child might be displaying to figure out if ADHD is part of what's going on for that child. And so that process does rely on taking into context the significance, the frequency, the severity of those characteristics and how they're impacting the child. And we're going to talk about this in more detail in just a moment. Complex ADHD, that designation there off to the side, is a term that's used to kind of identify a lot of what James was describing when ADHD does not exist in a vacuum. So a child who has other co-occurring conditions in addition to ADHD, or maybe their presentation is atypical, maybe they are presenting with really severe symptoms in that 5 to 6-year-old range when they're a little younger, or maybe there's other medical factors like genetic disorders or history of prematurity or seizures. All of these things make it more of a complex picture. So that's why we use that designation separately. So I mentioned those 3 different types, and each of the types have their own criteria associated with them. So when we're talking about ADHD inattentive type, these are the current criteria that we use to make that diagnosis. Oh, sorry, wrong slide. So when we talk about that overlap between autism and ADHD, there are definitely aspects of this that make it more tricky clinically, both to figure out if that diagnosis is appropriate and also the treatment. So in terms of diagnosis, part of what makes it more complicated is these overlapping characteristics, like James pointed out. So there are definitely, symptoms of ADHD that can look similar to some of the presentation of autism, and we have to tease apart in a lot of detail whether what we're seeing is a reflection of autism or is a reflection of an additional diagnosis of ADHD. We also have to think about the developmental context. So what I mean by that is that ADHD symptoms, to some extent, are a normal part of development at certain times in development, right? So if we think about a neurotypical 2-year-old, we would expect a lot of inattention, easy distractibility, hyperactivity, right? And those features of childhood development progress at different rates for different people. We have to think about where someone's developmental skills are at in order to determine if the inattention, the hyperactivity, the impulsivity are more than we might expect for where their developmental skills are at. So if a child also has a developmental delay or an intellectual disability in addition to autism, then we really have to tease apart, are these difficulties with focus, attention, sitting still, remaining safe, controlling your impulses, is that because of the delay in their development or their intellectual disability? Is that appropriate for where their development is at? Or is it more significant than we might expect based on their development, therefore indicating ADHD is also present? The other thing that makes this more complicated diagnostically is that we really don't have tools validated in the autistic population. We have tools that were primarily created and validated on more broad populations of people with ADHD and not specifically in the autistic community. So we're having to kind of use our best clinical judgment to adapt and interpret those tools with what we know about autism. For treatment, James mentioned earlier, we know that autistic children are less likely to respond to the medications that treat ADHD, and they're also more likely to experience side effects. So it definitely makes the path to treatment bumpier and sometimes can be a more challenging process to figure out what's the right treatment. Okay, so now jumping to the inattentive criteria. These are the current criteria for that inattentive type of ADHD. So difficulty focusing on details, difficulty paying attention, difficulty listening when spoken to, following through on instructions, organizing tasks, difficulty losing or misplacing things, easily distracted by stimuli or forgetful in daily activities. And like I said, some of this overlaps with what we might see as a manifestation of autism. So, for example, an autistic child may not seem to listen when directly spoken to, not because they're distracted, but maybe because they're not processing verbal language in the same way as a neurotypical child might. Or we heard earlier about the example where maybe a child appears like they're not paying attention, but it's not because they're distracted, it's because there's differences in how they're responding to that social interaction. So we have to really dive into the details during our assessment to tease apart what that manifestation or that symptom looks like, when is it occurring, how often is it occurring, and what seems to be the underlying root of that characteristic. For the hyperactive impulsive criteria, you can see them listed here on the screen. And again, some of those overlap with what we might see as manifestations of autism. So for example, an autistic child might seem to have frequent movements or fidgeting, but maybe that's not because they have that high activity level and difficulty with settling their body from an ADHD perspective. Maybe they're manifesting what we call a motor mannerism or stereotypy, where they're showing their kind of expressing anxiety or excitement through body movements. So again, we have to really tease apart where some of these characteristics are coming from to determine if ADHD is also present. And then for the combined type, that's when children manifest features of both the inattentive symptoms and the hyperactive impulsive symptoms. That's when they would get a designation of ADHD combined type. Okay, so what does this look like when a child with autism comes with questions of ADHD? How do we start to tease that apart? There are several steps to this process, and the process can vary depending on the situation. So your experience may look different than somebody else who also goes through an ADHD evaluation. It does really need to be individualized to that child and their needs. But these are kind of common aspects of the evaluation that are usually present. So first, we would do a clinical interview and a medical exam. So the clinical interview is where we would ask a whole lot of questions. For young kids, that would be primarily with the parent, the caregiver. For older kids, we would also want to get some input from the teacher and the child themselves about what we're seeing, how these difficulties are impacting their functioning, in what ways it's getting in the way of their ability to have, their best quality of life. We also need to do a careful medical exam because there are some medical conditions that can look like ADHD. So for example, if a child has a really significant sleep disorder, that can show up during the day, like distractibility, inattention, a hard time focusing because they're not getting good sleep at night, right? Or similarly, a child who is in pain might appear restless or having a hard time sitting still, particularly if that person doesn't use spoken language to communicate and can't tell us that they're in pain. We might misinterpret that as ADHD when actually there's something else going on. So really important to have a medical exam to rule out other medical factors that could be contributing. The next step would typically involve completing some standardized behavior rating forms. And this is where usually the caregiver, the parent, and the teacher, if the child is in a school setting, would fill out these forms to kind of better understand and to some extent quantify how these symptoms are impacting their functioning. And then for older children and adolescents, there are self-report versions of those forms where they can fill it out for themselves. And lastly, we involve some degree of developmental and or psychological assessments. So again, this looks different for each person. There's not kind of one set test that we would do for everybody, but this might look like assessing a child's cognitive development, where their learning is at, or their language development. This can help us, again, better understand that developmental context and determine if what we're seeing is related to their differences in development that we already know about, autism or developmental delay, or if instead this is related to ADHD. Now, there could be varied providers involved in this process, depending on your health system, as well as the child's individual needs. So you might see a pediatrician, you might see a psychologist, there might be a neuropsychologist, a developmental pediatrician, child psychiatrist. There's a lot of different folks who can be involved in this process. And it really needs to be tailored to that child's particular needs. Now, this kind of stands in contrast to, what sometimes is the experience for a child who does have that ADHD in isolation, where all of this might be managed by their primary care provider, primary care pediatrician. Most of the time for autistic children with ADHD, other folks are going to be involved. Specialists will be involved, at least at some point of that process, to make sure we're getting a full picture of what's going on. Okay, so once a diagnosis has been made, we want to turn our focus to how we're going to help support that child. And there's 3 different kind of options or pathways for treatment that we want to think through. So the first is what is referred to clinically as psychoeducation. And what this means is really just educating people about the diagnosis. So educating the parent, the teacher, and the child themselves about ADHD and how this might be impacting them, and how we can help support them. This in and of itself can be really important in, kind of increasing our understanding of the child, making sure we're accepting and appreciating the ways that they are doing the best they can, and understanding why some things may have been more difficult for them. The next 2 kind of options for intervention or support are psychosocial interventions and medical interventions. And depending on the situation, we might do one or the other or both, or we might do them sequentially. So there's no one path that's the right for everybody. You really got to work with your provider to figure out what's the best pathway forward for you. But we'll kind of talk briefly about what these 2 interventions might look like, so you can have a broader sense of that. And then you would definitely want to work with your individual provider to figure out what makes sense for your child. Excuse me. So psychosocial interventions is a broad term that describes, providing additional support to that child through therapy services, through classroom supports, and through kind of modifications to the environment. So we first can think about parent and caregiver training. So this would be working, either with like a behavior therapist, a psychologist, a parent coach, someone who would be working with the parent to teach them about the ways that we know we can help support kids with ADHD in their daily routine. Kids with ADHD, both autistic kids with ADHD and those who don't have autism, often benefit from different approaches to, the way we structure the home environment, the way that we move through our daily routine. And so working with somebody to help empower the parents with tools to know what might be a better fit for their kid is a really important part of this intervention. Classroom interventions is a similar idea, except we're doing it in a school setting or a classroom setting. Sometimes these are supports or accommodations provided specifically for the student, and other times classrooms might take more of a universal approach where we're applying these supports across the classroom because we know they actually can be helpful for all kids. So examples of this might be, using more visual supports, helping kids break down tasks into steps, and kind of giving them a roadmap for working through a classroom activity, having more frequent check-ins, frequent opportunities for movement in the day, because we know that kids with ADHD have high activity levels and need to move their bodies. So an environment that allows that and encourages that. Social coaching to help with them being able to build their interactions with peers, and lots of use of routine and structure to help them with learning new skills. And then as kids get older, move into adolescence, that's when sometimes organizational skills training might come in, and that's where you're working with the person directly themselves to help them learn strategies and tools to manage difficulties with inattention, distractibility, and impulsivity. And again, that would be often with like a therapist in a clinical setting, but sometimes a coach as well. So again, these psychosocial interventions sometimes are used by themselves. Sometimes that's kind of the treatment option, or sometimes they might be used in conjunction with medical interventions as well. So medical interventions can be broken into two categories. We have the medication treatments and non-medication treatments. So non-medication treatments are more of an area that I would say is emerging. And we definitely don't have as much research right now about the non-medication treatment options of ADHD. So they're not considered kind of standard of care at this point. This could include things like omega-3 fatty acids. We see some cognitive or mindfulness training, transgeminal nerve stimulation. These are all things you may have heard about in the news, and they're being studied, but they're definitely not as much research out there right now as the medication options. So they're not considered standard of care, but that certainly may evolve as we learn more about these options. Medications are broken into two categories. We have stimulant medications and non-stimulant medications. And then within those categories, there's a lot of different options in terms of the form, like is it a liquid, is it a chewable, is it a tab, is it a capsule, as well as the length of effect, how long does it last? And in general, stimulants, as James pointed out, we know they don't work as well for autistic kids with ADHD as they do if we look at a broader population of kids with ADHD who don't have autism. However, they are still the kind of most likely to be effective among the options we have. So we definitely look towards a day where we have better options. But right now, stimulants are often considered our first line option for medication because they are more likely to work than the non-stimulant medications. That being said, each medication has its own side effects, its own contraindications or reasons why you might not use it in a particular person. So it's essential that you're working with a provider to figure out what's the right fit in your situation. We would never make a blanket statement to say that's always the right path because there are definitely situations where we might go with a non-stimulant first as opposed to a stimulant. So you really need to work with your specific provider. Stimulants come in two categories, methylphenidates and amphetamines. These are two different kind of chemical approaches to treating ADHD that fall under that stimulant heading. And then the non-stimulants also come in two categories, the alpha-2 agonists, which includes things like guanfacine or clonidine, and then the norepinephrine reuptake inhibitors, which are medications like atomoxetine or viloxazine, if you've heard of those. So there are a number of different ADHD medications out there, and you have to figure out which one's going to be the right fit for each child. Lots of considering the pros and cons when you're considering medication management. It's not necessarily the right fit for everybody, and it may not be the right fit at every point in time. It might be something that's the right fit for a season of life, but maybe not later. So again, there's a lot of need for individualization when deciding about medications. But I just want to talk about some general concepts that I think are important if medication management is a pathway that feels right for a particular child. Number one, I think it's very important to have clear goals about what you're hoping the medication will help with. Medications are not a panacea. They don't help with every challenge that somebody's experiencing. We want to be really thoughtful about what are we hoping this will do, because that's the only way we can then monitor and know if it's doing what we're hoping it will do. We also need to have that clear plan for how are we going to monitor? When are we going to expect improvement? How are we going to know if it's working? How are we going to watch for side effects? Having a really clear plan for monitoring in mind. I am a huge proponent of trying as much as possible to only make one change at a time in a medication, because if you don't, it is incredibly difficult to know what has caused what, and you often end up in a situation where you don't know the next path forward because there are too many variables and it's gotten really muddy. So one change at a time. And in general, we really emphasize as few medications at as low of a dose as possible, right? We want to do our best to minimize side effects. So we want to be very thoughtful about medications and how we're moving forward. Being patient is important with medication management. It can take time to see the impact of a medication. And we need to give enough time to know that we have a good bird's eye view about how the medication's working, because there are so many things that might influence day to day how a child's attention and hyperactivity and impulsivity are affecting them. So we wouldn't want to base our decision after, too short of a time period, because there could be other stuff going on that's actually impacting the behavior more than the medication. And each medication has its own time to efficacy or amount of time we need to know if it's working. So again, your provider should be able to work with you to get a clear plan of when should I expect that this would be working? How long do we need to give it? And then always considering other factors. So again, going back to, is there something else going on that might be impacting the behavior we're seeing? And doing that regularly. Like each time a new challenge comes up or we're thinking about adjusting the medication, we always first have to go back to what else could be going on before we jump to changing a medication. And then just to kind of drive home this point, autistic kids have a trickier path to medication success. So often have to try more medications, more likely to experience side effects. We have to move slower on the dosing, and it definitely can take longer to get to the right spot than maybe a child with ADHD who doesn't have autism. So important to be prepared for that and kind of know that ahead of time, because it is a frustrating experience, and you kind of, I think, can be important to know what's coming down the road so that you aren't taken off guard by the fact that you have to try a few different things before you land on the right one. And then we all look towards a day where we have more targeted options that can work better to treat ADHD and autistic kids, so that the pathway is much smoother and isn't such a bumpy process. And then I just included a few resources here. The top two are from the CDC, talking about ADHD in general and the behavioral or psychosocial interventions. The third one down is a guide that's really helpful from the American Academy of Child and Adolescent Psychiatry. It's written towards parents and caregivers just about medication decision-making. And then the last one is CHAD, which is an advocacy organization focused on ADHD, and they do have some autism-specific resources on their website as well. So thank you all so much. I don't know if we have time for questions. And we're running a little bit behind. Well, till somebody says no, we can go ahead and take a question. I think there's someone down front.
Thank you. As you all stated this morning, it's very difficult to differentiate between signs of autism and HDH, whatever.
We know what you mean.
Sorry. So it is for you, so it is for regular folks like me. So as a parent or caregiver of an autistic child, what are the trigger signs that I should be looking for to say, okay, let's test and see? So far, we're to the autism level.
Yeah.
But we have talked like mom mentioned over there too, like we might be seeing something else.
Yeah.
So what are those flags that we should pay attention to it, and how do we move to that next diagnosis?
Yeah, great question. So I would say there's two things I think about. Number one, I think that all autistic kids should have their provider should be thinking about this, right? Kind of at each point along the way, their pediatrician or their developmental pediatrician or whoever they're following with should keep in mind this very high prevalence and be thinking about that. So there should be some degree of thinking about it all along the way and kind of keeping our eyes out. But the things that, would tend to tip us towards moving forward with an evaluation once we get more to that developmental age where we're able to assess that would be, difficulty staying on task at school or in therapies, having a hard time completing the work that the therapists or the teachers are working on. I always think about impulsivity around safety, right? Like having a hard time keeping a kiddo safe because they're climbing or their high activity level is getting them into unsafe situations. Those would be the things that kind of raise my flags a little bit to say we should look into this further. So how are they able to participate in their school, in their therapies, in their daily activity? And if distractibility and hyperactivity are getting in the way of those, then we should look into it. Yeah.
This is a question from the chat. At what age is it recommended to test for ADHD?
Yeah, it's a great question with not one answer. So James pointed out, typically we are thinking about making a diagnosis of ADHD around school age, 6, 7, is the more common time when we are able to assess that. Occasionally, there are younger kids whose inattention, hyperactivity, and impulsivity are so significant that we are able to make the diagnosis a little bit earlier than that. So there's not like one age I can give you. I would say typically 6 or 7 is when we're most commonly making that diagnosis, but occasionally a little bit earlier when the symptoms are so significant.